Hello everyone, good evening. This is Dr. Mukesh Porwal. As the president of Rajkot Ophthalmic Society, it gives me immense pleasure to welcome you all to this unique international webinar with Dr. ARUN GULANI. A warm welcome to all our viewers, our experienced panel of experts, moderators, and Dr. GULANI himself. Good morning to him in Florida. This masterclass is going to be very exciting and interesting with Dr. GULANI taking on the artistry, ability, and attitude of the eye surgeons and talking about them in dealing with the complex cases of cornea, refractive surgery, and cataract. Probably one of his last webinars, he says, so he'll be throwing in all his pearls into this one, I suppose. Knowing his style, it'll be everything. Surgery, artistry, oratory, all in one, and of course, science. So grab your cups of coffee and sit back and enjoy the show. I now invite the secretary of Rajkot Ophthalmic Society, Dr. Suketu Bapal, to share his screen and introduce our esteemed panelists, and then Dr. GULANI himself. Dr. Suketu, please go ahead.
Good evening, everyone. Good morning, Dr. GULANI, sir. This is our panel of experts. I will introduce them one by one. First is Dr. Sanjay Gadre. He is practicing in Rajkot. He is an eminent comprehensive eye surgeon, very experienced phaco and retinal surgeon, and now also an expert in flex surgeons too. He has a sharp clinical and academic mind. He heads the Gadre Eye Care Center. It is a multi-speciality ophthalmic care in Rajkot. Our second panelist is Dr. Vasant Sapovadia. He is also practicing in Rajkot. He is a pioneer of refractive surgery in the region, very experienced phaco and flex surgeon, believes in letting his work do the talk, and he's the head of Netradeep Group of Eye Hospital. His family is full of specialist eye surgeons. The third panelist is Dr. Tejas Shah. He is practicing in Ahmedabad, again eminent ophthalmologist and experienced laser refractive and flex surgeon, prominent speaker, teacher, and has a great sense of humor. He heads the Ahmedabad Eye Laser Hospital, and he has an institute of specialist ophthalmologists working with him. Our fourth panelist is Dr. Paras Mehta. She is experienced corneal surgeon in Baroda. First cornea fellowship. Yes, she has done a first cornea fellowship in the state. She is master of cornea and surface procedures. Head of Samit Corneal Center, Baroda. She is much sought after in corneal conferences. Our fifth panelist is Dr. Ajay Mehta. He is practicing in Rajkot, excellent phaco and refractive surgeon, versatile, high volume ophthalmologist. He is the head of Keshubai Mehta Eye Hospital, Rajkot. He will be speaking on intraoperative pupillary dilatation, the new approach, Phenokin Plus. Whenever we will take a break, he will be speaking on this. The whole show is based on Dr. Mukesh Porwal. He has done lots of effort to make it successful. Now to introduce our eminent guest speaker, I would like to hand over the mic to Dr. Om Patel. He will be introducing our guest speaker, Dr. GULANI. Over to you.
Yes, a very good evening to all of you. It's an indeed pleasure to welcome our eminent star speaker of the day, Dr. GULANI from Florida, United States. As we all know, he is a world-famous cornea, cataract, and refractive surgeon. He started his career in ophthalmology in India, followed by which he joined the Cataract Refractive Fellowship in United States. Following his fellowship, he decided to stay back in United States, although he has to repeat his residency all over again. He has numerous awards, publications, and presentations to his credit. He has designed many new techniques and instruments, and he is often called as Da Vinci of ophthalmology. We often find him as a prominent speaker in many international meetings. Apart from ophthalmology, he is famous for his style and substance, glitz and glamour, and he is no less than a fashion designer. He has a 100% premium practice with a global flow of patients. People and patients fly down from all over the world to Florida. He is famous for his never give up attitude even in the most complicated, unpredictable, and challenging cases. He believes in promoting surgical planning, which he calls as GULANI planning system, and his surgical skills over the technology and products. Thereby, he raises the surgery to an art. Today, he will showcase his different kerato-lenticular refractive techniques and how the unlimited combinations of this can help us deliver the best possible outcomes. So we have organized a special solo webinar to do justice to all his flair and skills. So without wasting much time, I will hand over the stage to Dr. Arun Gulani. The stage is all yours, sir. Please continue.
Thank you so much, Dr. Om, Dr. Mukesh, and great seeing all of you. Thanks for the invite. Today, basically, the reason I accepted this invite is about something I did not like in your emails. You all said you're a very small place with very small practices in the country. I absolutely refuse to let you keep that title. After today, you will never say that again. If you're ready to dominate the whole nation, get ready now. And you don't need coffee when I'm speaking. That's an insult to me. So here we go. I'm going to share my screen right now. What I will also do, Dr. Mukesh, that was excellent the way you sent me the questions from everyone. And my way would be I would rather share the concepts and answer the questions, because when you answer questions, it's the wrong way of teaching. People have to memorize. Once you teach concepts, you never have to teach again. People get it. So can you see my presentation right here?
Yeah, it's.
Can you hear me?
On.
Everything good?
Yeah, everything
All
good.
right, here we go. So absolutely. Artistry, ability, and attitude. I keep reminding eye surgeons, you were top in your college, so you became a med student. You were top among medical, so you became an eye surgeon. Don't ever forget that in any adversity. You're amazing in all ways, intelligence, ability, technical skills, so keep that going. I'll start with a very provocative video. As a resident in 1997, I said this. Corneal transplant is a reversible, preventable blindness in developed countries. Every word I say always carries a lot of weight. I don't just say things. This is very important. I believe in it. It's been 21 years since I've done a PKP. I used to do it in 16 minutes. Very proud of it. Never have more than 2 diopter astigmatism, but I used to hate the fact that I couldn't go below 2 diopters. That's what started my corneoplasty concept, where I wanted people 20/20 from scars. So here we go. That's my transplant over 2 decades ago. Never did a PKP after that. That's how people see after PKP. You nearly destroy their lives. Unless, of course, it's perforating, no discussion, that's understatement. But this is the reality of people who have PKPs. This is where corneoplastic became what I wanted it to be. Taking patients straight to vision and 20/20 in most cases, always without glasses and contacts. Watch these patients under the laser. These are very intelligent, demanding patients. Watch their reactions.
I see. This is an immediate difference. This is, oh my God, like I'm tingling from the inside out. This is fantastic. Any pain, Hector? No pain whatsoever. None at all. This is great. Very proud of you. I promise, no pain, everything. No pain. No pain at all. The doctors who are watching, if you can see up
I call this the circle of sight. A perfect circular reflex in the center, irrespective of the depth of the scar and the cause of the scar, translates to vision. I want all of you to look at this. Each and every patient of this is seeing 20/20 without glasses. Each and every patient of this. Actually, they all came together a decade later at the Institute to celebrate each other. These are patients of scars from PTK, PRKs, LASIK, herpes, acanthamoeba, trauma, you name it. They're all sitting here 20/20 from different parts of the world. As you all know, I believe in showing patients. It's the most dangerous way of having your work evaluated. Very easy to publish papers and hide in statistics. Cannot hide a fully paying, high demanding, high IQ patients. So no such thing as a nightmare or complication. Please don't ever talk like that, because that decreases your desire and the patient's expectations. Look beyond the cones. I wrote an article with the Porsche legend where I said cones in cars, as you know, is along the highway. You keep cones, so you divert yourself. I say, don't look at it. Focus on destination, visualize success. And thereby everyone is a candidate. Absolutely everybody is. I don't expect anybody to wear glasses. If they are, there's something wrong with them or the doctor that they are seeing. I always say this, and this is an article, an interview, show me the patient. If you all remember Jerry Maguire movie, that was after I used to say this as a junior resident. I used to say to my colleagues, show me the patient. I don't want to know what surgery you did. Don't show me the video, I'll throw up. Show me the patient that they're seeing perfect and they love you for what you've done. That is the only hallmark of success. Now for the refractive surgeons here, as I said, what would you do for a patient with nystagmus, +9 hyperopia, +7 astigmatism, strabismus, young girl, 25-year-old? Anybody, please. Anybody? Quick, please, quick. What would you do for this patient? 25-year-old, +9 hyperopia, +7 astigmatism, corneal thickness doesn't matter. I'll give you 560 if you want. Strabismus, of course, nystagmus, as I said, the eye is moving too. She absolutely wants to see. She was sent from South Africa. What would you do? Okay, let's
I would go for a clear lens extraction.
You would not. She's 25 years old. You would absolutely not. And how would you correct 7 diopter astigmatism on this cornea? So what I want to share here, docs, the beauty about teaching or talking to all of you is you're all excellent surgeons. Today, I'm going to bend your back and show you how to think different. You cannot throw surgeries and see what hits the ceiling. That's the wrong concept that I'm going to break today for everybody. Think for a minute what I just said. Young girl, 25. I didn't give you corneal thickness because it doesn't matter. +9, +7 astigmatism and nystagmus. What would you do? So laser plastic with a specially designed instrument you can see there, holding the eyeball as we are going. I'll talk to you later about what these concepts are, but that brings them exactly to 2020. And again, look at the patient when she came in and she just left last week following her second eye. This is their reaction. This is very important. No pain, and they're flying with confidence with 2020 with that concept. There is no limit to topography and astigmatisms of the topography. I don't even look at these things. I'll show you later in this scenario. The top topography there shows over 17 diopters of irregular astigmatism. I did something different there. While the lower one, if you see 10 diopter astigmatism, we did something different there. Both patients are 20/20. What would you do? Cataract surgeon, please. In this patient, 9 surgical complications following hexagonal keratotomy with 23.5 diopter astigmatism, 89 diopters keratometry, Fuchs dystrophy, cataract. Cataract surgeon, please. Anybody? Will you all agree with me? This is premium cataract surgery and you're aiming for 2020. How many of you will do that, please? At least think that way. Raise your hands. I want you to raise your hands once I'm done with you guys, all right? So this is premium surgery. The mindset is very important here. Surgery, yes, is difficult, doesn't matter. Your mindset is, I want 2020 for this person. So here's what we did, and I'll show you later the entire video. We put in intact rings, stabilized the cornea, controlled her irregular island of Hex-K, brought down the astigmatism from 23 to 1.4. When I did a premium toric lens implant to 20/25 vision, unaided. I always talk vision. It's never with glasses contacts. So here are patients now of corneal scars that I'm going to go immediately to show you. This actually is a post-op topography of that patient who's seeing 20/25 with the only eye with herpes central scar. I'm trying to prove to you topography doesn't relate to vision. All of you know that. Please understand this concept because I'll take you deeper into it. So this is why secret with scar patients. Look at what I'm doing. I have all the technologies in the world, but look what I'm doing to every patient who lands in my institute. Personally refracting them through their scars. This patient, by the way, is one-eyed with herpes central scar.
Yes.
And he works for Bausch & Lomb. No surgeon in the world gave him options besides transplant, that too with guarded because herpes, right? Here he is, 2025, and his life is back. Remember, very young man with this only eye. Yes, it's a risk, but you take risk with calculation and ability and attitude is what I'm talking about here. And why do we do surgery? This is what I want you to always remember. It's not just for a clear cornea, it's how you give them their lives back. This man, if I had made even one mistake, his entire family would be down. So these are the important things I like to talk about. Let's go to ocular surface right now. These are our today's patients who demand pterygium and pinguicular surgery. Many of you do pinguicular surgery, I'm assuming. Once you do pterygium confidently, you can do pinguicular, which is cosmetic. These are my regular patients. She is my patient always. And what they do nowadays is they literally go on social media the minute they've had surgery, even if you don't know this. They go and they start posting. So these are results of pterygium surgery immediately post-op, next day post-op, completely sparkling white, no pain, and ready to fly back. The procedure is what I've written in my textbook, sutureless amniotic surgery. You can see here next day post-op, how patients appreciate what they do. Lateral pterygium, same outcomes. Recurrent pterygiums who are sent, also same outcomes. So again, I'm stressing on attitude. Just because some surgeon did a surgery 4 times doesn't mean your surgery should look just okay. It should still look sparkling white. Patients with recurrent pterygium years later, how they appreciate what you've done. This is surgery. For time reasons, what I've done is I put all my surgery. My team is going to put it up on YouTube for you all. I'll go through quickly the nuances, so I'll give you time to question me.
This is a case of an aggressive recurrent pterygium.
And my aim is always remove the, this is all topical, remove the pterygium right up to the roots. That's the secret. Then I use a sutureless amniotic graft. Blade is used as eraser. Blade as an eraser, 64.
For about 30 seconds.
Mitomycin C in all cases. Glue under the amniotic graft. And patients are made to walk to a mirror next day.
Oh my goodness.
Again, for time, let's move on. Videos are all ready for you. And this is how patients note you on their internets and social media. Whether you know it or don't know it, or whether you're sleeping at night, they are talking about you and writing about you. And then if you are that good in your pterygium surgery, you can take it to these kind of multifocal premium cataract surgery. So you let patients enjoy not only the look of the eye, but turn them into candidates for premium surgery. Again, here, patient with amniotic surgery for granuloma, he was told not only corneal transplant, artificial corneal transplant in major centers in the country. Basically AMT surgery followed by ICL straight to 2020. This is the textbook if you need to read or order. It's online. It's on by team publishers. Then we come back to scars here. Patient with pseudomonas contact lens scar. You can see here straight for laser plastic to 2020 vision, 6.9 to 0.9 astigmatism. Any level of scar can be corrected with this concept. Patient with herpes scar, cornea down to 200 microns, 11 diopter astigmatism. What would you do? Laser plastique, no transplant. And one more important thing, she's a boxer by profession, kickboxer actually. So here she is, pre and post-op, and here is the person. So you cannot damage the patient's life because of inability. Please fight and get them to 2020. Here are scars of all levels. You can see them seeing perfect within minutes. And this is refractive surgery. Don't let anyone call this therapeutic. It's refractive surgery. And again, another patient, acanthamoeba, many of you may be seeing in your practices. These are also patients to see him for that same reason. Again, for speed, let's go a little faster on this.
I just finished doing laser on your corneal scar.
Acanthamoeba, remember, please. People say herpes, acanthamoeba can't be done. 2 decades of doing
a
it.
lot more clear, things are sharper, the raw image is sharp. Any pain at all?
Again, for speed, let's go. Once you understand scars, doing RK becomes a piece of cake. Here's a patient with 32 cut from Japan doing 2020 with laser plastique. Basically, you can interpolate scars into RK, hex K, whatever it comes up your way. You'll never get scared of it because just treat it like a refractive scar surgery. Again, how do I look at scars? About 42 different kinds of scars. I've divided into just in and on cornea to keep it simple. If the cornea scar is part of the cornea, as you see here, then it's refractive. Go straight for refractive surgery and proceed straight to 2020, even if there's residual scar. What is wrong about PTK is doctors are pushing and clearing the scar and leaving the patients hyperopic or blinded. That is unacceptable. Take the patient to refractive correction. Now, here's another in cornea scar. Look at this patient. Traumatic scar with 7 diopter irregular astigmatism. And this is post-op. Next day, this man has the audacity to put up a video on my Facebook. Let's see what he's doing here. Very important. Could he have done that with a transplant? Impossible. You gave him his life back, and this is next day. And on cornea scars, when you see these bizarre topographies, I call that the clown suit. Very bizarre topography. You don't go by topography there. You peel the scar off and take these patients to refractive corrections. And then here's another thing again. Remember, it never ends. 8 years later, this patient comes in for cataract.
In deeper on
so once the scar has been corrected 8 years ago,
technique, once again, proceed.
With full confidence, we are going in with toric premium cataract surgery.
2020 vision.
This is 8 years ago.
Very happy with poor vision due to was used the bag and prep. So this patient came from a blinding
and
the access
here we are.
to a 2020 outcome.
So this patient, give the patient his life back. So you can combine surgeries, as you can see in a summary here, how we took him from scarred pterygium to premium 2020. Then the gloves off series basically is how each of these cases you can manipulate into pieces, the top row and bottom row, patients with RK scars, straight to toric premium surgery after lens correction, after scar correction, sorry. Epithelial ingrowths of laser, same concept. You see me here, I've actually taken stitches in the flap. The intensity of this was this patient had multiple epithelial ingrowth removals by their surgeons abroad. And by the time we were seeing this patient, everything was mush, but you have confidence. And everything you do, you're thinking vision. So I used our own flap, stuck it down with topography guided, refraction guided pattern. In fact, I left it there with the stitches and did her cataract surgery later. Stitches don't matter in this case. It actually kept her in place. So I don't want to remove it because vision is perfect. That's what you're after. Patients like these who are referred with very high problems of multifocal surgeries, laser parquet scars, patients completely blind, suing the surgeon. Again, clear the scar, went in with piggyback lens to 2020. If I'm forced to do a transplant, like in this surgeon I've recently posted for y'all, 200 micron cornea, 16 diopter astigmatism, very irregular, cannot be measured. RK cuts are 21, 5 of them are full thickness deep. Then I do a hand lamellar surgery. Very simple tooth blade needed, nothing special. And you can see here, and remember in my mind, I'm constantly thinking I have to do his cataract surgery in the future. So the surgery has to land on an accurate cornea. That's my aim. And he's an oral surgeon, so very demanding profession, needs to get back into his life. Very easy to do a penetrating transplant. I think that's a losing mindset. Penetrating transplant, tell me the surgeon doesn't think. Each and every piece of his RK came into a piece. It was that deep. I've done thousands of RK patients. This man's every cut was like yesterday. And 5 of them, like I said, were full thickness, 100% deep. That's why they caused the scar. Another important caveat here. If you can do a lamellar surgery with a microkeratome or a femto laser, it means the cornea is not bad. So very important point here. If any doctor shows you doing it with a lamellar keratome or a femto, it means the cornea was excellent. The going down to the hand technique means no machine can measure or do this surgery. Very easy to master this surgery. You need just a tooth blade, nothing special, and you can tackle any corneal scenario. Here is immediate post-op. Again, remember, even though I was very happy and he's happy with this, I have one more step on my head. I have to still do his cataract, which we did 2 weeks ago, if you see here. So that's his sequence. I call this architect. Remember, surgeon, artist, architect. You're using pieces of your work to take people to vision. And again, smile complication that we are seeing so many flying to us now can be corrected with laser plastique. It's not the future at all. Laser ASA can be used for epikeratofakia. Again, see, the surgery doesn't matter to me. It's a scar, it's a thick cornea, go for it, get it, and straight to vision. And you can even take these decentered back to vision. Very rare cases that I have to do lamellar keratoplasty for cornea cases. If you have to, again, resist full thickness, there is no such thing as DALK. It's very simple. Go mid-stroma, fix these corneas, 6-minute surgery, no stitches, and then laser on top. And you're done with your work. And again, DSEC, DMAC, whatever you call it, it's been called GULANI keyhole transplant because I go in through a small incision, sutureless, put in your graft, but keep it refractively neutral. That's the beauty. Even in RK cases, refractively neutral. That's what I like. So I'll stop right here. This was my ocular surface and cornea section. Hope you guys saw everything you could. Any questions, please? Any questions at all?
Dr. Gulani,
yes.
When you treat the corneal scars, what kind of nomograms do you follow when you are planning surgery for these cases?
Doctor, by the time I'm done today, I want you to stop talking about nomograms, formulas, because I'm going to teach you artistry. Is that clear? Are you ready to get into the ring with me?
Absolutely. But we would like to understand that.
Because I'm going to put you into place with very important things. You'll have sent me all these questions. My desire to be here today is to make sure nobody ever can fool you on stage. All their complications are sitting in my institute. So the next question to you, what's the thickness? Because many of you asked this question. What's the corneal thickness where you do LASIK and don't do LASIK, doctor?
Not only LASIK, I mean, you do quite a lot of surgeries. I mean, you scrape the epithelium, you remove the scar, either you laser or sometimes even you dissect out the scars. But what is the, let's say, what is the final corneal thickness that you would like to leave behind? Or
Dr.
would
Hirsch,
you?
Dr. Hirsch, I'm trying to quickly get to you that is an improper question, and I'm going to force you to change your mindset. Here's why. So you give me a number first. What are you doing? You're an experienced surgeon. What's the number?
For LASIK, I would rather prefer to keep at least minimum of stromal bed of 250 to 300. 250 is my limit.
Stop. Who told you this number? And how did you arrive at it?
I learned it from my teachers.
Which
Many
is the
of
teacher?
my gurus. Quite a lot of senior refractive surgeons.
Doesn't matter, doc. I just asked you, how did that guru learn this number? Because I've gone to 140. Doesn't matter. I'm going to teach you something very important today. It's just like saying, is a 4 feet tall guy tall or short? A dwarf is abnormal. A giant is abnormal. Others are relative. Especially in the Indian population, I see so many complications coming for LASIK problems. Most corneas are thinner than Caucasian corneas, if you've seen them enough.
Yes.
Thickness is not important. Determine normalcy. Then plan your surgery. Another problem all of you have is you all constantly talk LASIK. There are 20 laser vision techniques. Think about it for a minute. You're giving a burden to everybody. You're deciding between who's going to throw up, who's going to enjoy it, and who's going to eat it. You're a master chef. Decide what the patient needs. Plan your surgery. Every patient then is a candidate. I will show you cases where the cornea is down to 140. It's now 15 years follow-up and no cross-linking. So what I'm trying to say is very important. There is no such number. And whenever I pull up surgeons in world meetings, they freeze because they don't know how they came to that number. They just learned it from someone who was mediocre enough to keep pushing it down the road. There is no such number. I have fixed complications of every surgeon on this planet. I'm telling you, here's how you think. If you need to do laser vision surgery on a patient, your approach shouldn't be, how can I do laser vision? It should be, what does the patient need? Is there a scar? Is there normal topography? Is there astigmatism with the rule? In fact, astigmatism against the rule is more important than topography to me to determine abnormal cornea. If you see those things, you have a red flag. And you don't think, now I will do PRK. Again, wrong. Think among 40 things. What can I do to get the vision and plan this patient's future? So my answer to you, there is no such thing as minimal thickness. It's a completely fabricated number. Yes, you have to be safe. Yes, you have to determine normalcy. And LASIK is the cause of a problem because you're cutting the cornea. That's where your problem is. If you do surface laser surgery, you can go down to 140, provided the cornea is normal. Now, you saw me do this on the patient with the intacts. You'll see me in the later cases.
Yes.
Because the intacts in place. And other important aspects to understand, astigmatism takes the least amount of tissue. So when you understand these concepts, you will never again mention numbers and nomogram. By the way, my nomogram doesn't change at all. Doctor, one more question I got 6 times. My medication protocol doesn't change for anyone. It's the same. So I'm constantly trying to show you doctors who have made these protocols, I've made them come to my institute and beg for mercy because I made them say it on stage that they are wrong. So I'm just trying to make sure you guys don't fall into this trap. There is no change of medication. Never use alcohol and all that garbage on the cornea. Manual lamellar Tukes blade. And that answers Dr. Porwal's question. You have it in Rajkot. Got it, guys? Okay, go ahead. Next question.
Did you manage?
May I ask you one thing? Would you prefer? Would you say you prefer surface ablation rather than LASIK? Given a chance, anytime you would prefer to use surface ablation or LASIK?
Doctor, again, you're wrong. Would you prefer burger or hamburger or a hot dog? See how you're asking me a question. I'm going to again take you back and push you to the wall. Give me 40 techniques. You're a master chef. You will never think this way. I get this all the time. 16 emails a day from renowned surgeons. That's my record. 16 emails a day on average. Dr. Gulani, if I can't do LASIK on this, what can I do? Can I do PRK? It's all 16 questions are the same. Amazing surgeons from different parts of the world. So much confusion. Never. I'll show you how to think, doc. I'm sure you guys are amazing surgeons, so I'm just going to push you with attitude today. I'm not going to talk surgery. So this whole concept, if I can't do LASIK or if I'm not sure about what's going on, I'm going to do PRK. That's a loser's attitude. Whoever says that on stage, pull them down. It's wrong. That means you're not sure about your work. You should be rock steady and don't give patients options. That's the other thing I got a question from Dr. Porwal in your list. How do you handle celebrity patients? Guys, who is the celebrity in the room? You. Are we clear? No one can be more demanding than you. You stood first in your med school. You stood first in your ophthalmology exam. Who the hell is better than you? So I'll come back to your question, but I'll answer it with concepts. So you'll never, ever, ever ask like this, because this is the most bizarre question. If I'm not sure, doc, this is K conus, should I do PRK? No such thing. Does it deserve a PRK? Does it deserve a laser plastic? Does it deserve an ICL? And why? That's how we'll go. All right, next question.
Sir, my question is, how did you manage the +9 and the +7 cylinder?
Very good. Laser plastic. So when you take refraction, this is the part that refractive surgeons are not taught. Put it into a spherical cylinder. Okay? A spherical cylinder, refraction, and then put that refraction. You saw me refract patient? See that? Yes, no? Can you hear me?
Can you repeat again? No.
Any refraction, if it is beyond 7 diopters in astigmatism, you convert it to a spherical cylinder to the sternum, a conoid of sternum, and then you refract them and get to a number, which actually in her number came down to +5 -4, and straight to 20/20. The other issue I had with her eye is nystagmoid. So I developed an instrument, the SECO, which holds the eyeball. And I do these eyes one eye at a time, because every such eye, you want to see how you landed, correct? Also, wherever she was seen in South Africa, London, everywhere they told her she's also amblyopic. I don't believe any patient's amblyopia until I've refracted them. So she actually refracted to 20/30 from 2400. Remember her glasses, please. This young girl who came in with so much trouble, left dancing. So if you look at refraction, I will show you how that decides your direction. That is the biggest key I want to give you today, is refraction decides your direction, and then you will never question yourself or the patient of what to do surgery-wise. All right? So if you see the scar patient, the attitude part, one-eyed patient with herpes central scar and works for Bausch & Lomb. Do you want anything more to be a sure lawsuit? Are we clear? But your desire is to help the patient. I sent him to all his 9 surgeons all over the country and made them say that this is the man to fly to. So we record, of course, that's all paperwork. My point being, you can fix it. And you gave him his life back. Sure, you can do a transplant. Transplant's a surgery a junior most resident should do. Pterygium is a surgery a senior most resident should do. Pterygium is artistry. Transplant is bizarre. Brain dead, exchange of manhole cover, 16 stitches, you go home and play golf, patient screwed forever. Right? Next question.
But what do you tell the patients when you are faced with these complex cases, that how much vision you're going to give them back?
First of all, you don't say that, correct? Can you say that to your retinal patient, Dr. Purwal?
Not really.
See how wrong you are? First of all, I'm confident in myself. So you don't tell patient, you tell the patient, listen. First of all, to me, my practice is unique, right? They've flown after seeing 6 surgeons, so it's okay. But I sit down for 2 hours if you've seen me, personal, one-on-one. I said, listen, I understand your situation is difficult. Herpes, which no surgeon operates on. Central scar, you're blind. 3, it's your only eye. I do believe my laser plastic will work. The backup is a transplant. I have never had to do a transplant, Mr. Smith, let's call it. And if it even comes to that, I'll do lamellar. I'll keep resisting. I'll keep doing lamellar till I, God forbid, never fail. But if I do, PKP, which is what all your surgeons are giving you. Isn't that true?
Right.
Oh, doctor, this sounds perfect. And the surgery will take 4 minutes. I will know within 5 days how we did. That's it. How can you guarantee a patient like this with vision? But you are guaranteeing yourself that you're going to fight to the finish. So that's what I'm trying to teach as attitude. I know I got these questions also from you a lot. How do you talk to the patient? The patient understands your honesty. They get it. You're not selling anything. They're like, listen, if you need me, this is my plan. I'm not giving you options. And yes, I can do a transplant 22 minutes. I will not do it. You're too young. Are you with me, Dr. Purwal?
Yeah, I understand.
Does that answer your question?
Yes. So
Perfect.
in other words, you need to prepare your patients for multiple stages of surgeries.
No, I don't. Never. I tell them, this is my only surgery for you. In my mind, I have a backup plan, which I do not let it come back to my mind on the day of surgery, because then you're planning for failure. I never give myself a second chance, ever. That's attitude. Again, right or wrong, that's how I function. I do not believe in taking a parachute as I jump off the cliff. Only then will you fly. It's a very important attitude aspect. I do not like doctors having plan A, B, C, because then you will go to B or C. Yes, next.
Sir, suppose you have to do multiple surgeries together. You prefer to do them in a single session?
Never. So Dr.
For
Herschel,
example,
Go ahead, sorry. Yes.
If you are supposed to do multiple surgeries, for example, you have to do surface ablation, you have to remove the scar, and also do a cataract, you would prefer to do them all in a single session in a single day?
Never. Never. Correct? Why, doctor? Never. Why? Come on, doc. It's a cocktail, isn't it?
Yeah, it's a cocktail.
Yeah, I'm a single malt guy. So my point is, you want accuracy. You're not operating for the heck of it. That's my first statement in my first slide I showed there. I do not want surgeons showing me triple, quadruple procedure. To me, that's like a brain dead guy. I can't even look at that surgery. I'm like, you just screwed up the patient completely. Because, understand two things now. Among all the surgeries, you have accurate surgeries and you have inaccurate surgeries. Are you with me?
Yeah.
Accurate surgeries are everywhere you take the patient to vision and refractive correction, lasers, lenses, ICL, whatever, right? Inaccurate surgeries, or what I call structural surgeries, are, for example, intact lamellar keratoplasty, fixing the cataract in a certain anatomical problem, whatever. All that's inaccurate but structural surgery. Structural surgery you do to prepare for visual surgery, accurate surgery. But you can't mix two accurate surgeries. You cause a cocktail now. Think about it. If I do laser, I've changed the refraction. Now, how dare I go inside the eye and do cataract?
Inside there and do the surgery.
Exactly.
Okay.
So I'm very firm with the patients. I don't like just this week. I sent the patient back to California. He's an attorney, 32 cut RK, subluxated cataract. I did his first time. He's blown away. He's 20-25 next day. He wants to stay back for a week and for me to do second. I said, no way. With this kind of RK, I will wait 3 weeks. So patients understand you. I get it, doc. I'm not going to budge. I don't give you an option. So that's the point, doc. So very important point I want to state to you, very simple of the way I speak. Accurate surgeries, architectural surgeries. A transplant is not an accurate surgery. An intact is not an accurate surgery. A subluxated cataract fixation or arranging the zonules or fixing the capsule is not accurate surgery. Visual surgeries are visual refractive surgeries. These are very precious. You cannot play with them. You have to be very focused what you're going for. All right? Does that answer your question?
That it does. Thank you. Thank you, Dr. Gulani. That was nice.
And again, Dr. Harshal, before you ask me this question and I get tough on you again, there is no such time interval. It's all an art. Correct?
It is an art. I accept.
10 times. The surgeon I just told you, where I worked on the lamellar keratoplasty, correct? And then to toric lens, I made for a year. Until I'm convinced that the cornea, again, 2 words. See, the way I teach is very simple. Until the cornea is stable and measurable. Forget all the terminology. Absolutely. Because, doc, you're entering the eye, which is a sacred area. And remember, no plan B. You're not going in with, I can change this lens later. No plan B. Plan A, success. So I went in for this lamellar K guy, surgeon, and did his cataract, and I call this arrogance of vision. I didn't want to take a stitch. So all these cuts on the periphery, the lamellar areas in the front, no stitch, and more arrogance, toric multifocal surgery. 20-25 next day, and you see him dancing, it's on the post. But a point, you don't give options. And the patients start respecting that aspect. This is what doctors are missing all the time. Patients don't come to a doctor going, oh my God, he'll give me options and I'm the one who's going to decide. They come to you with trust. They go, okay, whatever you say, doc. Because we're coming to the next very important topic, premium lenses, and how doctors are in trouble with that, right? Any next question? Cornea, anybody?
Dr. Gulani, I just understand that for pterygium surgery, you prefer to put an amniotic membrane graft instead of, what we have been of late doing is conjunctival graft instead of amniotic membrane, because the results of, recurrence are much lesser with conjunctival graft. So how do you rate this procedure against that? And
so I have had one recurrence in 18 years. My paper was just published, cosmetic pterygium surgery, and I've written a whole textbook on this. And again, if you see the patients, where doctors are still lagging way behind where I want them is, I don't care if you used conjunctiva, amniotic membrane, bone itself, skin, I don't care. Get me results. So in my hands, I've had one recurrence in 18 years. But what is important, doc? And I'm okay. I don't want to debate anybody using autograft, this, that. That's waste of my time. What's important is, can you make your patient walk to the mirror next day and they look sparkling white?
No, but we are looking at the long-term results. We are not looking at just the short-term results.
No, doc, not short-term. I want outcomes day one. Cataract could have been a long-term result. I've been pushing for 28 years. Today, some morons came up with the word refractive cataract surgery. I kept on saying on stage, how can you do cataract without zero emetropia? Oh, we removed the cataract. I'm not interested. Similarly, doc, I'm saying I love your surgical skills. I'm not questioning that. You see where I'm pushing you for attitude. I want next day in the mirror. I don't want this leg to be recovered at 1 month and then it's fine for 20 years. I want next day in the mirror. It tells me how good a surgeon you are. And there's been no recurrence for 18 years. How long is your follow-up, doc?
See, I'm telling you that, like, with a conjunctival graft, obviously the patient would not be able to, see the same way in the mirror on the next day.
Doctor, how long is your follow-up? What's your study?
At least 20 years.
20 years. Beautiful. So you're close. My point, can you now make me happy? Make your patients look great the next day. So you already convinced me that you're not having recurrence. I'm happy.
They would be looking at the mirror by 3rd or 4th week, and that would be almost equal.
I'm fine. Do they look gorgeous?
Absolutely, yes.
Then I'm happy. Show me your photos, please, next time. I'd love to see. So
absolutely.
I'm going to push you. Surgery is not what I'm asking. Surgical skills I've been teaching for years. My point is, guys, now I'm pushing attitude. I cannot have a pterygium patient with blood or cautery being used in pterygium. I don't want that. So I'm just pushing you. Can you make me happy? Show me your next day patient in the mirror. And not you. The patient should post saying, I'm looking amazing. All right? Can you do that for me? All of you.
Yes, we can. The only thing is, I couldn't really somehow, follow that with an amniotic membrane staying there for a very short while. How do you get, very minimal or no recurrences?
Doctor, it's in my book. It's in my patients. My patients for 20 years are on Facebook, which is unbeatable evidence because they can write whatever they want. But more important, what I'm telling you is you stick to your technique. Just help me push to next day cosmetic. When LASIK started in 1994, I was already measuring my patients at the 2010 line. All surgeons told me, Dr. Gulani, let's wait for a week. They start seeing at 2 weeks. I'm like, why? So all I'm doing is pushing you because I know that's possible with you. Your skills are good. You've had good results with no recurrence for 20 years. Can you make me happy? Take the patient to the mirror. This will do one thing for you. It'll put you on the spot. But the patient's not going to blame you. They don't expect to see that great next day, right? Sparkling white. But you will understand that there is a little more level to improve the surgery. With me? Doctor?
Yeah, I just got, but somehow, I'm not very convinced about it.
I'm not here to convince you. My work is not to be convinced. You can see it if you have the ability, put your patients on Facebook. I've defied the journal people. They rejected my paper of 20 years of corneal scars at 2020 in the world's most litigious population. I'm doing this only for y'all to help you. You can take your time in evolution and come to where I am, or I can push you to get there faster. So I want pterygium patients in the mirror next day. If you cannot do that, don't come back again. I don't want to see your results. I want you to think it's your daughter. I'm going to come to keratoconus and I'm going to smash you again in that same area.
Right.
So it's okay if you do good surgery, doc. I want you starting to feel embarrassed about taking the patient to the mirror because you know it's not sparkling white. I want you to be embarrassed. That's the first step of success. Right? Next question.
Yeah, I think it's time to move on to the next segment, premium lenses, if you can.
So what I'm going to do here again, doctor, for all of you is a lot of questions. A lot of surgeons are in trouble, not only in India and Asia and Europe, but in the US. And all the time they call me and I keep telling them that where they're causing the problem, it's themselves. So let's go here. Next section. So what is premium surgery, doctor? Who's a cataract surgeon here? Great. So doctor, what is a premium surgery to you?
I would say a patient who has clear ideas about what vision he wants. He wants to see for distance, he wants to see for near, he wants to be able to drive, he wants to be able to, say, work on a computer. It means a kind of vision where he was comfortable before cataract, the same kind of visions he wants after the surgery.
Doctor, I asked what is premium surgery. That's the patient's demands. The patient can demand anything. He wants to see the moon in the morning and the sun at night. That's fine. What to you is premium surgery? Because I'll tell you where this is for all of you. Go. Go.
To give such a result wouldn't be a premium surgery.
No. Premium surgery, where I'm trying to go here is, lot of surgeons are in deep trouble all over the world. This is the primary reason patients are flying to me. The first reason. The second is cross-linking problems that are increasing now. First is still premium cataract surgery, and the patients are unhappy. So I'll tell you what's going to be changing here. It's not your fault. It's the way the industry has put this together and the way you are going with it that you have become a victim, all of you. I'll show you how. So first of all, as a premium surgeon, you take responsibility. In my practice, we don't advertise at all, but you can do whatever. It's all your style. Believe in yourself, just plan. And then here is how I talk about premium surgery. It's all about the ability to deliver, the ambience, the outcomes, and technology is the last thing I discuss. Here is the biggest mistake doctors do. Premium surgery equals a premium lens. Is that correct? That's how you put an axe, you sharpen it and put it on your own foot. So this is premium surgery. Complex cases, why they're dancing out of surgery. Or when I'm in their eye, we are talking. This is no anesthesia, please. Drops only, all the time. This is a patient from Abu Dhabi with 9 previous surgeries. And I'm talking while I'm in his eye. He's had 6 different things on his cornea. And this is the day of surgery, comes on a bike for me before flying to Abu Dhabi. And my confidence in sitting on his bike, this is day of surgery. This is an Army, a US Coast Guard officer with 20 cut RK with 9 diopters. You sharpen it and put it on your own foot. These are patients with anterior segment reconstruction. Notice no stretcher, walking out. Why should no anesthesia, please. Drops only. So premium to me is everything. How you work your entire practice. This is a cycle of how patients are going through my practice right from the time they arrive. The day of surgery comes on a bike for me before flying. I'm getting an echo. My confidence is sitting on his bike. This is the day of surgery. Hello. This is an Army, a US Coast Guard officer. Oh, I'm getting an echo. Something else, right? Can I'm hearing an echo.
It's from the video, I suppose.
Okay, so this is the reason why we do things. Maligo?
Somebody's mic is unmuted. I think everybody should mute their mic except the speaker.
It just is sound is coming.
Are we okay? Are we okay now? Lovely.
Yeah.
So as a premium surgeon, doctors, what I'm trying to say is it's you who's premium. All right? There is no need to sell anything. There is no need to give importance to the lens or technology. It's you. And that's very important when I talk premium. All kinds of technologies are available to us and all kinds of techniques. But this is the 3T system I talk about. First, go to target, which is what vision you want to plan. Then go to technique. And then finally, technology. And this is the GPS system that I've talked about a lot. It's how we think. I always think vision. And that's where, Dr. Herschel, especially with your questions, this is how I decide what I need to do. And then I walk back to my kitchen and look for what I need. And then I come out with one plan, no options. No going to the kitchen and seeing what 3 things you have today and how can you make that food. That is the backwards way which all doctors are working on. Therefore, they go burger, hot dog, falafel. That's wrong. And planning is most important, please. Very important. So let's go here quickly, doctors, and I want cataract refractive surgeons. How many of you here, please? Wonderful. So, doctor, here's the patient. Keratoconus patient who had premium cataract surgery with their surgeon landed hyperopic surprise with astigmatism, anterior corneal scar. I said keratoconus, so high keratometry. And the surgeon further did a YAG capsulotomy. So patient is miserable, 2200, wants a lawsuit. I repeat, left with hyperopia, astigmatism, anterior corneal scar, high keratometry, and pseudophakia with open capsule. What would you do? Quick.
Anterior corneal scar. How deep is it?
Superficial.
Can we do a surface ablation and get rid of the refraction?
Doctor. First, think of all the things I said. Remember? No going to the kitchen yet. So here's how I think, doc. Literally take a pen and paper and write down. I call these pins. I'll show you later. You know, you bowling?
Yeah.
Bowling pins, right?
9 pins.
Lovely. So, doc, take a paper and write down all I said. Astigmatism, hyperopia, anterior scar, high keratometry, right? And pseudophakia about open capsule. Now, here's how I think, Doc. Plus, anybody else, quickly, what would you do? Please, fast. And remember, I want 2020. I'm not even thinking how to save. I'm thinking how to give. 2020. Quick.
Piggyback lens.
What's that?
Piggyback lens. Head-on lens.
Yes,
So
yes.
frankly, Arun, I believe the answer is making flight to Jacksonville, Florida.
Okay. That's fine. But doctor, come on. Today is very important that you stay where you are and make Rajkot your center, right? So here's how I think, doc. You lined up all the things for me, doctor? We have everything, right? All the problems here. So here's my plan now. The one surgery that will get me my anterior scar, flatten my keratometry, clear my center, correct my emetropia for this patient and bring him to 2020 is myopic laser surgery. Are you with me?
Yeah.
The problem, damn it, is this is hyperopia. Now what do I do? So see how I'm thinking. I call this going to Iceland before going to Paris. So you saw my pins there, right, doctor? All of you?
Yeah.
Now, I want to strike. I don't want any pin standing. So what I do is I tell this patient, here's a ticket. Me and you are going to Paris. Yes, I agree. But first, let's go to Iceland. It's dark and cold, but you have to have confidence in me. So I first go and I put a piggyback lens and make him myopic. 3-minute surgery, same incision as his surgeon, correct? Topical? Yes? Now I make him myopic with astigmatism with anterior scar with high K. Then I go straight to Paris. I do my 4-minute myopic laser surgery. We are 2020. In fact, he's 2015. He got a pilot's license. He's 68 years old. So here is that patient. How cool was that?
Extraordinary.
But first, I'm going to bash Dr. Porwal now. Anything that you cannot do in Rajkot with this?
Everything can be done. It can be done.
That's the answer. So I want no excuses, guys. If you think vision, you see how simple it was? 3-minute surgery, 3-minute surgery, patient sitting on your, and patient is rooting for you. The patient's clapping, Dr. Gulani, yeah, let's go. Here's the problem, doctor. Dr. Porwal's question. What do you tell the patient? In fact, remember when I made him myopic, his vision got worse, right? You must be thinking, what the hell happened here?
But in keratoconic eye, do you do myopic LASIK?
What's that?
Keratoconic eye. Would you
Doctor,
do
That's next.
No, doctor, never LASIK. Never LASIK. This is laser plastique. You do surface surgery. Remember, so you're getting the scar, decreasing the keratometry, correcting the emetropia. And here's another quick thing I want to go into and come out quickly, doctor. Yes, you could go into the eye and I could show off my surgical skills, remove the lens, stitch the lens on the sulcus, do the vitrectomy. Are you getting 20/20, Dr. Harsha? No way. You just screwed up the entire eye. And you left the problem right there, the scar and high keratometry. Night vision is poor. So you see, if you plan vision, you're actually giving the patient far beyond what he wanted. His surgeon just flew him to me because he was facing a loss. He said, Arun, can you please fix the lens, take it out, do your whatever you do? I'm like, no. This is what I will do. So in fact, his surgeon looks good now because we left the lens in place. Patient is blown away. This patient has sent me his wife. He sent me 6 of his friends from all over the country. Do I need to advertise, doctors? Can you do this in Rajkot? Can we do this in Rajkot? Exactly.
It can be done.
Absolutely can be done, guys. Come on.
Can be done.
So what I'm constantly showing, this is a herpes patient. Actually, this patient had laser twice. Herpes scar, he's a farmer who came to me. I did laser plasty. You can see the scar, about 21 diopter astigmatism. He saw beautiful. He delayed his cataract surgery. Then I went in and did his cataract surgery. Here's the best part. He came to 20/30 unaided vision. Here's the best part. My patient. Doctor, can I see 20/20, please? In my life, I've told nothing can happen. He's been to all the places, Cleveland Clinic, John Hopkins, you name it. I said, okay, gung-ho. Here's my risk. I've never done herpes laser twice.
Hi, good morning. How are you?
Got it? So we did laser again on his herpes cornea for the residual astigmatism after his cataract, 20/25 vision. Are you with me, guys? Ready to jump onto K-conus now? Yes? You will change the way you practice. Yes? No excuses. Everybody. No talking the stupid LASIK smile and cataract again. That's technical level. I want artistry. I want architect. I want wizards. I want people who don't give up on patients and look like amazing rock stars. Are we ready for this? Yes? I don't see yes, guys. Okay.
Yeah.
Yes, Dr. Ajay. Okay. Keratoconus. What would you do for keratoconus, doctor? 28-year-old patient with 9 diopters astigmatism, 2 diopters myopia, 440 cornea microns. Let's make him 40-year-old. What will you do? Quick.
I don't know about United States, but in India, you definitely do a cross-linking there.
Doctor, there's no difference between United States and India. All right? You're global. Rajkot is global, correct?
Right.
Yes.
At least today it's global.
It is. Has to be from now on, guys. Has to be from now on. All right. So again, guys, and I'm forcing Dr. Harshal, poor thing, he's the guy getting all the bashing. Think vision. Doctor, if your 26-year-old's only son has keratoconus, all right, will you do something as silly, and don't pardon my language, please, I'm very tough on doctors. Will you do the stupid cross-linking and put him in a hard contact lens for life? Was that what you were going to do? Answer, please. Yes, no.
I thought about it.
Pardon me?
I thought about it. The first thought that came to my was that then I realized I have to think out of the box.
Outside the cone.
Outside the cone.
Okay. So my point is, doctors, cross-linking a patient. Back, so he won't bend anymore. Now, if you're in lovely, yes, exactly. So, if you're asking that question to the orthopedic surgeon, what about you? Yes, no. Did you all wake up? Still need coffee?
Yes. So we should do the same. Try to flatten it as much as we can.
No, doctor. No, I'm not saying flatten. I'm saying make them see. I don't care about flattening, Steve. I don't speak in that language. I want vision. So your only child is going to this top-notch eye surgeon in Rajkot who says, I'm going to cross-link you. And the mother finally asks a simple question from the corner in a meek language. Said, doctor, but won't that mean that my son's cornea is going to be bent forever now? Yes, that's what you're doing. You're creating disabled people. Right, Dr. Om?
Yeah, I agree with you.
You are creating disabled people. I have 15 to 18 patients a month who call me, also from India, all over the world. I've been cross-linked, I can't see, my doctor says nothing else to do. How horrible. You put cement on a bent back and you left them out in society to deal with a contact lens. Would you do that to your only child? So, doctor, having said that, everybody clear with me now? Yes or no?
Yeah.
Yes? So you see how this concept is so wrong? And doctors having confidence on epi on and epi off, that's brain dead, man. You don't even know when to do it. Cross-linking is the most amazing technology, but use it to permanize your vision. After you made the back straight, whatever way you did it, now permanize the vision. Are you with me, guys, everybody? Only place to cross-link without surgery is young patient who's changing up till 18, 20 years of age, right? And you want to stop it. I agree with that. But otherwise, cross-linking K-conus patient randomly, I call it linking without thinking. You got it, everybody? That's a keratoconus patient. These are the keratoconus patients that I worked on. Look at them in the professions that they are. How demanding can you be? And 2015 and 2020 visions, no glasses, contacts. How many of your K-conus patients see 2020 without glasses? You all do see keratoconus, right, doctors? How many of your patients see 2020?
Very, very rare.
Forget rare. Do you even have one?
Very.
Yes, I have sent you a case today. If you've seen that patient's presentation, and C66 part, 2020 part.
Okay, okay, very good. So we'll go through that. My point is, Do your keratoconus patients see 20/20 without glasses after you're done with them? Or do you just put cross-linking, send them out the door, and they're lost to the world? Isn't that what's happening?
No, but after C3R, we can do ICL, phakic IOL, and then patients can see 6/6.
Very good. Exactly my point. So either do it before or after, but plan vision. To me, C3R is just a way of stabilizing or permanizing. How simple is my language? Stabilizing or permanizing. That's it. There is no other indication for CXL. Whatever you call it, CXL, CCL, whatever nonsense, and epi-on, epi-off doesn't matter. I've been doing epi-on for the last 2 decades. That's the way to go, but doesn't matter. Whatever technique works for you, vision first. So keratoconus patients like these who are sent to me, this patient had cross-linking in 3 places, Canada, Miami, California, completely blinded. One guy was smart enough to do ICL, but he did not follow GPS. Remember GPS? The direction has to be correct. You can't just start driving. You have to decide where the destination is. So they put in the ICL, then did cross-linking and landed with scars and poor vision, laser plastic straight to 20/20. So I'll keep going for a reason of time. Lasers can be done on keratoconus provided there are criteria that they meet. More than 40 years of age, more than 400 micron cornea, stable cornea, stigmatism more than myopia, they can be taken straight to 20/20. In fact, these are my patients. I first do the laser, as you can see here, 2015, then did the cross-linking. This is a firefighter, as you can see here. And night vision is amazing. So don't think keratoconus doesn't work. They see. Here's my keratoscoliosis concept that you'll understand after what I said. Cannot just put cement on a bent back, correct it, and then put cement. These are all firefighters in one day when I corrected all cones, different surgeries, ICL, cataracts, intact, different techniques. Works on various amount of corneas, actually just for stabilizing after you permanize them. How many of you do intacts, please? Nobody. You should, please. Intact, scleral ring, ferro ring, whatever you call it. Very important, please. Very important technique to stabilize and brace your cornea, and then do laser or ICL like Dr. Vasan just said. Patient with intacts, you can see here, this patient had multiple LASIK complications and came to us, and you can see me while I'm putting the ring. You can see his reaction right under the table. This is what I call the titratable intact technique, where I look for the reflex. This is the glue I'm using. I don't use stitches for any surgery. So this patient, you see the reflex coming up, and you see his reaction under the laser. So all you've done is modified the shape of the cornea. Got it? Now for I think Dr. Korwala, who asked me, what's your backup plan? I don't have backup plans, but in my mind, if I had to, the lamellar channel of the intact becomes my lamellar keratoplasty backup. How's that? Simple? Patient crying, a tough patient, high IQ patient. But this is the reaction, guys. Are you with me, guys? Everybody. So you can take astigmatism from 10 to 0.1 in 4 minutes. That's keratoconus. Got it? So then, like Dr. Vasan just said, if you put in an intact in these patients and you made them more measurable, now you can do laser to correct the astigmatism straight to 20/20. Right? No big deal. And again, keratoconus is nothing more or different than ALK or LASIK ectasia, so you treat them both accordingly. You don't fear these patients who are flown to you. You can look at it like a cone and fix it accordingly. Here's a patient who just went back home from Egypt. He had 6 different surgeries in India, Dubai, London, Egypt, Canada, everywhere. This is a Kerr ring in his place. Cornea is just 300 microns. People who ask me about the cornea. Now that the ring is in place, doctor, instead of blaming all his surgeons, he's had multiple cross-linkings, PRK, PTKs, all that stuff. You start refracting the patient. You start refracting the patient, despite all these problems. Straight laser plastic, seeing under the laser. In fact, I did a second eye 10 days ago, and he's flown back yesterday. So a lot of stuff to show you, but I'll just keep going for speed reasons. No limits on topography at all. Now, for cataract surgeons, many of you may have seen some of these I've shown in my previous webinars just to teach the concept. So cataract surgeons here, please. Anybody? Lovely. So doctor, what would you do in this case? We discussed this, right, as we started, what we did here. So I'll take you straight to the planning concept, how we brought 23.5 diopter astigmatism to 1.4 with the rings, and then I'll take you to surgery, and I'll go through this fast too, just so you can get the gist of it.
This is a 75-year-old nurse who was referred to me following hexagonal keratotomy with corneal ectasia, vision of count fingers only, and Fuchs dystrophy, along with associated cataract. and high keratometry of 88 with high irregular astigmatism of 23.5.
अच्छा तो ये जूनी बॉटल पता है नवी बॉटल तो खाली है
in sync for future cataract surgery. Here I am using Intacs, and as you can see me, I'm using
It's
her own
manual
corneal
technique.
resistance to guide
You can
my
do this in
extracting
Rajkot.
place.
All right,
I'm doing
guys,
this without
everybody.
any sharp intervention, so I don't make mistakenly
Manual
any
in these
incision that
cases
can
because
go
you've got to be
into the
careful. A
hexagonal
machine will never
keratotomy
understand
cuts
how
and
not to cut
perforated
into the
cornea.
hexia and how
Again,
not to cut
notice these
into
are
the
very
limbus.
determined yet very careful movements
So I'm using the
of the
cornea
ring,
always as
and I'm
resistance
placing
guided
them so as to
platform.
embrace the
So I
central
just came up with a
unstable
plan. Can I
iron.
control the
The
hex K
success
by
of this is
embracing it with
immediately
Intacs?
reflected in the
And
central
then
light
fixing that
reflex
stability and then
stenosis,
going into,
which is becoming
like
more
Dr.
and more
Vasan said, we could have done
circular, and I hope
ICL, but
that
because she had
titratable,
cataract, I did a toric
concept of
cataract.
intact
So there's no
surgery.
limits
Notice
what you
again,
can
the
do.
light reflex is now a
Once you
perfect circle.
stabilize
I'm
the cornea.
extremely pleased to the
Dr.
point where I confidently
Harshal, this is a
trust
rare time that I'm
This success is
cross-linking at the
reflected in
same time because
topography
I'm
from
very happy with the
23.5 to
reflex.
1.4
So I
diopter
fixed her.
astigmatism.
Look at
Patient
her. After
extremely
60 years
happy,
of
comes
blindness,
dressed
how they
next
dress
day to
up.
meet me.
That's
4
what you
months
want.
after
Now, 4
determining
months later, I'm
stability
now
of
going
this
to do
cornea,
cataract through
so
this.
we can
Again,
determine
remember the
accurate cataract
arrogance.
surgery.
No
We
stitches.
proceed
I want
here.
perfection.
Trap and blue for
This
the
is just for
observing
visiting surgeons. I
surgeons.
did trap and blue.
Viscoelastic
And this has to be
exchange.
manual.
I
A
plan
femto
my
laser cannot go through
capsular
all
rexes to
these
be a smaller
disturbances and
size
do a
so I can
proper
see the
rexes.
edges between the hex
Small
K cuts
rexes to
and
keep the
intact
diaphragm. She's also
deflections,
fuchs dystrophy,
and also
9
to
different
maintain a
problems
good
with her
lens
eyes,
and capsular
exophthalmos, thyroid,
diaphragm.
lots of stuff.
I now proceed with what we call phacoplastic, which is doing
Cataract surgery, the way I do,
also
has to be
determined steps.
artistic.
Like you see, my
Not moving
phacoprobe is
around and
not
futzing
moving
around
its
in the eye,
face
very
in one
important.
place, while my
This way
second
your
hand does
incision
most of
remains
the movement
sutureless,
to
even in
maintain
these
a
cases,
stable
because we've
incision.
entered before. Remember,
Similarly with the
Intacs,
IA and lens
she has a
insertion
bad cornea
here.
from the hex
Lens
K.
is now being
Still, I
placed
don't
in the
want to
bag
stitch.
and then
And
gently
again, the
moved into
arrogance,
its
we're using a
axis.
toric
Again,
premium lens
irrigation
here.
aspiration, well-sealed incision, further
Because of
reinforced
travel, I'm
with
putting a
Restore
Restore sealant
sealant.
just for
No
added
stitch
measure.
to induce any astigmatism. So here we have taken a patient who was denied her vision for 60 years in few minutes surgeries, 4 months apart.
4
We have
months, Dr.
restored her
Herschel.
vision
4 months
and her
here.
confidence
Stability.
to give her back her life, where she's come back to nursing and helping other
She
patients.
joined Mayo Clinic to be
Here
a
she
nurse.
is immediately after surgery.
This is how she used
Here's
to look.
my payback, seeing them smile and free to lead their life and help others. Once again, thank you for your attention.
So, doctor, to me, I don't understand cataract surgeon unless you show me this. I'm not interested. Showing white cataracts and the same stupid Argentinian flag sign, same dropping nucleus, same posterior capsular rexus, same garbage fixing lenses and having conferences. I mean, it's brain dead. This is cataract surgery. And now I'm coming full circle, doctor. This is premium cataract surgery. Are you all with me? Yes? Everybody is a candidate. See how you can change lives. This patient who came in looking old with exophthalmos, hex K, 23 diopter astigmatism, 88 keratometry, everybody in the country, nothing can be done. Just think vision. Don't listen to the noise. Someone's hungry, coming up to your kitchen, you have to provide the meal. You cannot just say burger, hot dog. Wrong. Go and make the meal. Be a master chef. 500 ingredients, unlimited recipes. Perform. So patients are faking implants. Many of you use faking implants. Of course, ICLs, Verisize, and you'll have lots of stuff available. Again, it's just to manipulate the optics, right? See how you can even do amniotic surgery. This is what I call architect level. You're taking different specialties of yours and stepping it together. Patient who was told by everyone in the nation, corneal transplant and artificial corneal transplant. Amniotic graft, 6 months later, ICL 2025. Cataract surgery again. Patient who's had 21 cut RK plus 14 astigmatism, flown from Boston. What would you do? Has cataract, 14 diopter astigmatism, 21 cut RK, miserable, hyperopia, sorry, plus 8, you can see with his glasses. Nurse by profession in one of the top institutes in the United States. What would you do? Come on, doc. Come on. Quick, guys. So, what up? Yes, Dr. Harsh, come on. Someone's talking. I can't hear.
These are some kind of patients which I have never faced in my life, and I don't think I'll face such a situation again.
Who's this?
Can you hear me, sir?
Yes, I can.
So, I don't know how to correct the 14 diopter astigmatism with an intraocular lens.
Doctor. Okay, let's stop right there. After today, you'll never say that to yourself again. All right? So, again, remember, there's someone who's come to your door for a meal. You cannot send them hungry. Can I push this formula anymore for you? All you are is a cataract surgeon. I don't want anything else. And I'll tell you, you'll use equipment that is in Rajkot. That's what I'm going to show you too. So I want no excuses. This is basically cataract surgery. So cataracts, seeing white and black cataracts. Okay, I'm hearing echo again.
Hello.
I have an echo again.
Dr. Gadre is speaking.
Dr. Gadre is speaking.
Yeah, can we do a customized sort of lens for this particular patient? Because we have something called a smart toric. We send all the readings to the company, and they send it across, and then we can correct 14 diopters as well.
So doctor,
let
me bring you back to where I want to be. I'm hearing an echo. Did someone turn their mics off?
Yeah. So, is it possible in this patient?
Doctor, everything's possible, and you don't need any smart tools. And you don't need any company to tell you what to do. That's the whole point of today's webinar. I want
Dr. Gadre, sir, can you please switch off your mic?
Okay. Can you hear me now?
Yeah.
Lovely. Well, my point of today, being here with you. Echo. Someone else is on.
Sir, Dr. Gadre, can you please? That's fine.
Are we okay now? All right. So my point again is, guys, I don't want any company telling you what to do. You are the smart person here, not the smart toric. With all due respects, and I'm always first with technology, but today I'm trying to teach you how you are the rock stars. So first and foremost, if you're a cataract-based surgeon, you can do this. All I'm trying to show you is all these levels of complexity doesn't change your ability or your attitude. Remember, that's our talk today, attitude, ability, artistry. So even though this patient has all these issues, my plan is very simple. I want 20/20, I want no stitch, and he flies back to Boston next day. That's my aim, and I don't have plan B and C, right, doctors? So we go in, I measure him, I don't look at the topography, refract him, and his astigmatism actually is 6 diopters, and hyperopia the 8 diopters, and we go in sutureless and we do the surgery. In fact, that day was the first in the world. We used intraocular Dexicue, if you know the medication, the steroid that we use in the eye, instead of drops. So we use that too in him, which means, again, you don't have to compromise quality. You can keep going higher. Remember the levels what I teach? Surgeons who are doing cataract, LASIK, SMILE, and just busy and confused between white and brown cataracts are at a technical level. When that technical level becomes empathic and knowledgeable and consistent is surgeon. When you do it with artistry, and then you use architect. Architects, you take your artistry in pieces like we're discussing now. To 20/20. Finally, he's become a wizard. Nothing fears you, right? So we took this patient. You can see a quick video of the Dexicue, which we did in him. The third case is his case. Yeah, that's him. And so he's going sutureless back to Boston. We are done. He's 20/25, just came back for his second eye. Don't need anything smart, doc. Simple surgery, toric lens, you're done. Another patient, mature cataract. I know you guys love these a lot. This is a patient who came with both eyes mature cataract during the COVID time without telling me, was driven overnight from Washington, D.C., Virginia area, completely blinded. And I had to let him go through COVID testings and stuff to even accept him. Both eyes mature cataract. Every surgeon scared, worried what to do with him. Simple. Just do it. Just do it. So other thing I like to celebrate all the time is I don't like the nonsense of this is difficult and this is nightmare and this is blue. Let's put trypan. Let's do this. Just do it, please. It's simple. White cataracts is the first year resident should do. So you can get over this fear that is created for all of you. It's not difficult at all. It's piece of cake. You see both eyes right there next day post-op. More important, the patient reaction. This is how the patient entered my institute when he came. He couldn't walk. He had to be brought in by people. Can you see that? Can you hear? Doctor, can you hear?
Yeah, can hear you very well. Yeah.
No, he's coming in. Okay. Yeah. Then you go. This is how he left. This is how he left. Doctor, can your white cataract patient do that next day with both eyes white cataract and the patient wants to do it for you? And the guy who's pointing at him is a brigadier who was flown in the previous day with similar problems. So he's laughing at him because they both were shot. Isn't that funny? You've seen all this on my social media. Patient, and remember again, the world's most high IQ patients, these are the most demanding, already seen 6 or 7 surgeons before they come over. So they are not the fun type, they're actually skeptical. Yet they react this way. I'm trying to answer Dr. Porwal's point, how you react to patients. So I'm trying to teach you that. So these are all cataract surgeries. I call this dominate, every cataract. This is a harpoon I've designed, but you can use whatever you use. Please don't need to buy anything.
Case of
again, I'm going to show you aspects. This is a patient with dense cataract, only seeing eye, pseudo-exfoliation, posterior dense plaque. Patient was flown to me from, I think, Midwest area. And you can see the rexus is difficult, very, very elastic, super elastic. And I don't drop my principles. That's the important. I'm still folding it on itself, not rushing. Surgery will still take 6 minutes, but cannot lose focus because he's difficult, only eye, very demanding, blah, blah, blah. Doesn't matter.
Capsular diaphragm, the
and because it's pseudo-exfoliation, you see how I'm using the cataract. This is another thing. I don't put in instruments in the eye, hooks and stuff like that unless needed. I use the eye and the anatomy to my advantage. You'll see how when I crack it, I use the pieces, keeping against the zonule. You see that? This is my harpoon. Takes a second to break any cataract. And you see me breaking the posterior plaque, the leathery plaque, very important in these cases, right? All of you are experts in this. I don't need to show you surgery. What I'll show you here is quickly the reaction.
Once again, on another section, we see this maneuver. Deep down, break the
see how I'm breaking it to keep the
posterior plaque,
zonules without stress, not on one side.
Separation. Break this cataract into small. Pinch it along the axis.
Again, premium. Here he is immediately post-op.
Along the axis.
I want you to appreciate this is artistry. This is artistry. A demanding patient right out of surgery, talking and smiling with you, no drugs, no stretcher.
Everything went real well, and my eyesight is 100% better. It's so good. I can notice on the lettering that I could not see before. It's like the lettering on your white.
Do you get it, guys? This is what I want. Just doing cataract surgery is technical level. Look at this patient. A legal, paralegal, both capsules adhere to each other, traumatic absorbed cataract with an eye with multiple vitreoretinal surgeries, and what do? Again, no worries. You want vision and you want perfection. This is him day 1 post-op. I'll show you the surgery again, time as we don't have time. I did an anterior axis, a posterior axis. There was hardly any cataract, removed that, put a lens in between the 2 capsules, and good night. We're done. So nothing is difficult, guys. But if you change your focus from vision to surgery, you'll be scared every day. Oh, this is difficult. This I can't do. This I don't have technology. If you think vision all the time, you start driving with full confidence, right? How many times do you drive every day to your office worried about getting into an accident? How many of you do that? Please raise your hand. But isn't that what you're taught at all these conferences? Look at this difficult case. Look at what I did. I'm like, you idiot. Why did you do that? It's very simple, guys. Very simple. You cannot let a surgeon have a posterior capsular rupture. It's not normal. It's not normal. When people send me this video, Dr. GULANI, can you look at this? How did I do? I'm like, why the hell did you tear the capsule? Oh, see how I managed. I'm not interested. I'm not interested anymore. That means you're not a surgeon. You're a technician. You don't feel for the patient. You have to be me 2020. All these cases I'm showing you is because I know you can do it. So again, if a femto laser, which I believe in tremendously, but there was another question Dr. Porwal had in his list. Here's what I say. Doctors are very confused. They keep asking me, just like your LASIK question. So do we need femto laser for cataract surgery? And here's what I say. You can use a pressure cooker to make a cup of tea. Do you need a pressure cooker to make a cup of tea? No. Are we clear about this, guys? Master every technology. You are the master. There's no company who's smarter than you. You are the smartest person in town. Take charge. So, femto laser, when I teach the nuances, but I also teach how to handle things when they don't go well. And yes, 11 years ago when I did one of the first femtos literally in the world, I also wrote a big supplement for CRST Europe where I wrote about which cases actually need femto. Subluxated cataracts, white cataracts, etc. Not every case. Of course you can use it for every case. Is it needed? The answer is no. So here is where we are salvaging a capsular rexus when it's not completed with the femto. Again, follow your principle. Don't be in a hurry. And don't blame technology. Remember, the patient you cannot blame. So you're folding the capsule, going gently, finish your stuff. Just perfection. Again, I use anatomy of the eye. I'm not quick to put in hooks and capsule or rings and all that nonsense. Have you all realized after doing surgery for over 30 years that the less time you spend in the eye, the better the eye looks? Have you all realized this? Isn't it amazing? I mean, you see these videos that you're being showed where people are going in and out all the time. The patient's screwed. So this is, again, PSC cataract, a posterior polar, sorry.
In this case of congenital posterior polar cataract,
so again, see nuances. Nuances.
Delineation.
No, you should not have a rupture of capsule in these cases. Yes, they have a high incidence, but you should not have it. Plan your surgery. This is what I call layered delineation. You all know this stuff. But important again is patient reaction. Again, premium lens surgery. And here's a patient back to his professional cricket. Very important. How to use the situation of the eye. Here is the patient, entire epinucleus in a patient with weak zonules. I left it till I finish all the cortex. Watch that maneuver again. Just use the anatomy to your advantage. Don't have to put in all these instruments. Can you do this in Rajkot, guys? Yes, correct? Don't need any special stuff. And oh, by the way, look at the patient reaction. This is very important. Yes. And again, please, none of the patient have drugs, no anesthesia, no stretcher. This is right out of surgery. Very important. Here's a patient yesterday, he came in for follow-up. This guy's a captain. He's called into captain when ships are difficult waters, and he's the guy who they trust when they go at night or difficult times, huge ships and trailers. So his eye had massive asteroid hyalosis, as you can see, and my visibility very poor. But I used a wisp of cortex in his posterior capsule as my guide to know that the capsule is intact throughout surgery. That's the case here. So here we go. So as you can see here, I'm done with the cataract. There's a wisp of cortex on his posterior capsule that's floating. That's my cue, because even his cortex looks clear. Just look at that. You just don't know where you are. There's so much of visual issues. But I'm using the wisp right there at 6 o'clock, which is my cue that the capsule is perfect and is down there. So I'm working my way again. Cannot take a shortcut. That's the attitude part. And I want to deliver 2020. He's a captain. So remember, all these things are in your mind and there's no plan B. I haven't planned a vitrectomy in him at all. So that's the attitude part I want to show and teach all the time. These are not difficult cases. Use the eye to your... Do you see that wisp of cortex at 6 o'clock? That's my cue. If you see, I'll show you in high mag shortly. Now I'm entering the bag. Again, full confidence, premium cataract surgery with toric lens. And I'm showing you the wisp now, which was my soul mate in this situation. And the captain then yesterday actually posted, he said, when I go through the dark nights with these difficult ships, I too have to find something that I can cue my direction with. And the point is the passenger should not feel the pain. Again, he gets up fully fine, happy, and here he is, immediate post-op. His asteroid doesn't bother him, by the way. He's perfect vision, he's fine, so don't do anything that is not needed. Here he is, immediate post-op. So small things, how to lift the iris in deep chambers, as you can see here. You know, some in deep myopic chambers, the iris goes down. Patient feels pressure. You want the patient to feel nothing, artistry. So you lift the iris up in these cases while you're operating. Here's a patient with femto laser we did. I usually need about 3 millimeters dilation to do my cataract safely. I don't put anything unless it goes below that. Here's a patient with hard cataract, pseudo exfoliation, small pupil. After doing the femto, the pupil came down. Yes, your phenocane can be used here. More importantly, how do you salvage the situation? Remember again, don't blame the machine. It's you. So there's a nice rexus sitting there, but the pupil is very short. So I put in a ring here, Malugan, after making a decision, go in, dilate, perform my thing, remove the cataract to that very small rexus, and then enlarge the rexus. Do you see me doing that? Right? We are done. More important, I keep showing you is the patient. If the patient's in pain and unhappy, you failed. I don't want to see a surgery. Patient with extremely deep chambers, 20 cut RK, went to possibly every country and was sent over, very difficult with severe blepharospasm, very deep orbit, so very difficult access and her RK cuts. But what do I want, Dr. Harshal?
You want the best for him. You want to give him vision.
Her, 2020. And I want no stitches, ever. I want no stitches, remember? So, and access difficult, but here
she's... And white eye on day one.
Pardon me?
White eye on day one.
White eye, yes.
Yeah,
But important in these cases, because they're complex, is can you confidently let them fly? And see, more importantly, what she does immediately out of surgery. Very important, again, the psychology of the patient. She was so let down and hopeless, poor thing, gone all over the world, and been told very difficult, we are not going to do this. And you can see her reaction from a very depressed person, how she comes out of surgery. And remember, no stitches, and here she's immediate post-op. See how deep the orbit was, and through that 20 cord artery. Now watch this. You can change people's lives. You can change people's lives. Please, I don't want to see just surgery. That is the lowest level, is kindergarten. Next time someone shows you a white cataract or a sublux, just tell them, stop, please, I need to leave. Artistry, performance, attitude, and then the patient is your only, not only the guy who blesses you, but the person who's actually evaluating you. Correct? Here's the patient, nystagmus. Okay, cataract doctors, are you ready? Or refractive doctors, who do we have here? Doctors? Yes.
Both cataract and refractive surgeons are all here.
Okay. All right, let's go. So patient with 11 diopters astigmatism, keratoconus, nystagmus in the eye, -11 myopia. Albinism, that's not important to you, but that's what he is. What will you do? So here, let me repeat again. He is PSC cataract, a posterior polar, sorry, high myopia, 11 diopter astigmatism, as you can see here, nystagmus. Others are not important, amblyopia, albinism, etc. What will you do?
He needs a colored intraocular lens.
Pardon me? He needs what?
A pigmented intraocular lens.
Why?
So that the light is shielded out, pinhole lens.
No, why? Why? His iris is perfect.
He is albinotic, so there are no pigments in the iris.
No, you can see the iris. Look at his eye.
Right.
There's no such thing. Albinism he has, yes, the retina is albinotic, and his whole face, you can see the skin, hair, everything, but iris is perfect. Do you agree? Yeah, nothing like that. Again, doctors, think vision. What do I want, Dr. Vishal here? Dr. Harshal.
2020, but did you do the refraction? What was the astigmatism you noted when?
11 diopters.
No, but that's what is written over. That is what is written over here. What is?
It's the same in refraction. Very good question. I love it. Yes, same on refraction. That's why I'm saying it. Very good. I love it. We are going somewhere here. Come on, doctor.
So he is accepting a very low cylinder?
Pardon me?
He is accepting a low cylinder.
My man is very high.
He's 11 diopters.
When you refract him for the cylinder part, he might be okay with a 3-cylinder or a 2-cylinder.
No. That's what I just said. He is 11. I like the question from Dr. Harshal. He is 11. Correct. Absolutely correct. Anyway, let's go. So in this case, we are planning a stage surgery. Okay. So first, what I want in him, and second, what I want, Dr. Harshal. Remember, to enter the eye, the sacred eye, you have to have a stable and measurable cornea. Everyone agree? Otherwise, entering is criminal, right? You cannot enter and then come out with a mistake and then go, oh, now we can't do anything. So in his case, what we did was, because the cornea was stable and measurable repeatedly, my only other issue was the nystagmus, but that's okay. We know how to handle that, right? With one hand and then do the cataract. So posterior polar cataract done first, high toric T9, right? Corrected him completely, left him with, I actually shot for 1 diopter myopia, because myopia always gives you a better center. You with me? So then I came with laser, and myopic astigmatism laser on his cornea, bang, 2025, we again proved the amblyopia guy is wrong. He still has nystagmus, he's still albinoid, but guess what? We are done. See the nystagmus, please. So iris is perfect, doc. Here he is. Nothing higher than that as a proof. Nothing higher than that. So guys, we're talking about cataract surgery here. Is this cataract surgery? Are we okay? Yes? Nothing special. You don't need any company that's telling you to be smarter, smart toric, right? You're smart. They are the toric. Okay, let's go.
This is what is to be done for all the patients.
He posted recently. Cannot hear, cannot speak, tracheostomy from carcinoma, cannot hear, head nodding, head movements, nystagmus, plus 30. Shallow chamber, white cataract. Straight to 2020, just cataract surgery. Don't worry about anything else. No big deal, right? Here he is. I made him open his eyes for the first time in the only stadium in the world with pools in a football stadium. Look at him dressed up for me. Let me take you back a little. That's how he used to look. Do you agree you can change people's lives? And you're a doctor. You can do fun things. I called him on a Sunday because this is the first time he's seeing. I said, dress up for me. I'll show you a sight you've never seen before. Made him open his eyes. The world's first, we were in the pool in the football stadium. So guys, you can do this for your patients. Get it? No doctor is too busy to have fun with their patient. Look at them, how they change. Next. Now, how many of you see these patients, which is the highest reason for patients flying to me, unhappy premium cataract patients? Come on, guys, raise all your fingers. Yes. Biggest problem here is doctors are selling lenses. You should be yourself premium. Here's what I like to say. Watch this. Agree? Agree? Guess who caused this problem? You did. You did. Oh, let me offer this lens. Can you pay extra for this lens? And the patient thinks the lens did the magic if it works, right? And if it doesn't work, the surgeon was so stupid, despite me spending so much money, I can't see, or I see halos and glares. Everybody, yes? So never, 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 never. The lens is a great part of your planning. You are premium. Don't forget that, please. This is the dogma of what I teach all over the country. All surgeons in trouble because they keep selling lenses. Patients then don't understand the difference between Dr. Harshal and Dr. Porwal. They just pick up the phone and go, I want that lens. How much will your doctor do it for? They just destroyed the differentiation factor. Are you with me, guys? Everyone, yes? Everyone getting it? Change your style, please. It's you. Dr. Harshal, XYZ years, most amazing, blah, blah, blah. Dr. Gadre, severe experience, amazing surgeon. That's the premium part. His lens is just an ingredient. You're the master chef, man. Take your reputation out. So you're with me, guys? Any questions on that? This is the basic reason why most eye surgeons in the world are in trouble. This is the number one reason people are flying to me. Number one second opinion reason in my institute is this. This is also important what I say. A menu is not given by surgeons. So what do you do in these cases? Again, surgical acrobatics is very easy. What I'm constantly teaching you today is to think vision, right? Don't jump and change the lens and remove the lens. That's failure. Correct the vision. Everyone agree?
Yes.
Wonderful. Then you can use laser. Only very rare, extremely rare for me to remove someone's lens. This is a patient, she's a physician from Idaho. She was 17 diopters irregular astigmatism. The surgeon put in 4 lenses, in and out, in and out, in and out, with RK. She has RK too. And finally send the patient over to me, ARUN, do something. Now, here's my question now, guys, because we've gotten very good now, right, everybody? Why the hell did I remove her lens and not do laser? Doctors, I never remove the lens. I like to fix the whole camera, leave what the surgeon has done, because that's anatomically perfect. Why did I go in and do this through her RK? Quick, guys, quick. Why am I doing this? Again, most surgeons are taught, remember, correct me if I'm wrong, that if you put in a wrong lens or multifocal, you remove it, put the monofocal, correct? Never do that, ever. This is, again, you know my technique I've talked about is 28 years ago. Putting the other lens on the lens, blah, blah, finish it. Come on, guys, quick. Why did I do the lens surgery, not the laser or anything else in this case? Guys, come on. Thought process.
Least minimum surgery for maximum result.
That's correct.
This would have been the best option.
Why but? Why did I in this RK 17 diopter astigmatism decide to do a dangerous thing of going inside and again removing the lens?
To make him myopic? And then
No.
do the...
Very good point. No, she wasn't myopic. Good point. Okay, quick. So the cornea had stabilized, even though it was ectatic. The 17 diopters was topographic. Doctor, you forgot to ask me the question I asked you. Remember? Refraction. So I refracted her to 7 diopters astigmatism. Her cornea has been stable, though ectatic. Looks horrible. And also her surgery was just 3 months ago. And I thought, if I now do anything with laser, first of all, I'll get the astigmatism, but the whole refractive arena and the way the lens has been set is wrong. That means I'm still leaving a little bit of bad night vision. So I calculate her over 3 visits. She stays in town, measure her. I'm convinced, plus her doctor had measured her for a year before sending her over, consistent. Now I go and remove that lens, put a proper toric lens and position it, and we come out 2025. And for the first time, she said, Doc, I can see tables and floors straight in my house. And that's a doctor. Everyone okay? All right. So
this case underwent laser corneoplasty.
I'm just going a little fast. These are cases where you can now use architect knowledge. You're already an artist. You know what to do with scars, what to do with cataracts. Now you piece it together after stability and measurability straight to 2020. Here's another patient from Switzerland, extremely high myopia, posterior polar cataract, keratoconus, high astigmatism. What would you do? So I stabilized the cornea first, put the intact rings, brought down the astigmatism, stabilized. She's pretty young, so I stabilized the cornea. Then toric lens surgery, straight to vision, as you can see here. Back to Switzerland. She, for the first time, flew back to Switzerland on her own because she could finally see. Everyone with me? Very simple surgeries can be done in Rajkot. Yes, no? Yes? No big deal? Super. Here's another patient I showed you initially, patient with extreme scarring following multiple PRK because her surgeon had a multifocal nightmare and went to 2200 vision in a lawsuit. So first make the cornea measurable, correct? Corrected her cornea, cleared it out and got nice refraction, measured her. She was hyperopic. Because she already had a lens and open capsule, piggyback lens, straight to 2020. Here's another patient. So with this patient, I want to take you through my thought process. So this patient had 12 surgeries before. Keratoconus, scar, PRK, PTK, cross-linking, ICL, intacs, and now has anterior subcapsular cataracts. What will you do, doctor? I've written it up there for you. Go. What will you do? I can't hear. I can't hear it, doctor.
Refract fast.
Very good.
See where if your refraction and the your topography and everything matches, then go with the IOL power calculation and use the best IOL available. I think that's a single step surgery that will give the best result.
Stop. So I said anterior corneal scarring. Second, you're absolutely right. The end point here is the cataract has to be done accurately. Correct? And if you've done enough of these surgeries, you know the ICL doesn't affect the biometry. Correct? Everyone okay? Can you hear me? I can't hear you.
Yes, sir. Exactly.
Clear with that, right? The concepts are clear.
Yeah.
So I first do laserplasty, clear his cornea, make him measurable, and then you're right, I stabilize, I measure. When I'm very confident, I decide I can go into the eye. Of course, I'm planning ICL removal lens. Now, here's what I did different. Even though I was very confident here, because he's had 12 different surgeries, just to be safer, I did what I call the aphakic technique. All right? I went inside, removed his ICL and cataract, left him aphakic. Measured him next day, measured him 1 week later. Piggyback formula, put in the lens, 20. 20, yes.
20.
Here we go. So here you can see, I did his surgery, left him aphakic, came back, put in a toric lens, and here is his video. I'll show you actually on a bigger screen. So that's his journey with me. This is not Iceland to Paris. It's actually forward journey. I'm not going up and down. Forward journey, stages. This is his video. A little fast again for you.
Who has undergone multiple refractive procedures on his keratoconus.
And all of you can do this, guys. Answer is yes, correct?
Cross-linking intact.
Very simple stuff.
Had very poor
ICL
vision,
comes out
further
through same
added on
incision.
by his anterior subcapsular
Cataract comes out through same incision.
Given that I
Only
could
difference
not
here I did is
measure
I went
this
extra
correctly, I
mile.
planned a
It's a
stage
more work
test
for us, more
that would
expensive for
first
me, but you
start with
always do what's
AKM
right for the
and then
patient.
measure him
Left
and
may
then
fake
treat
it.
him for a
Again,
lens.
remember, the patient has to trust you, have confidence
So
in you,
here I
right?
am,
All of you know how to remove an ICL, piece of cake? Yes?
ICL, and my
Everybody?
technique is
Yes?
always maintain elegance, come out the same
And
way
again,
the lens
don't make
is
extra
made
incisions and
without
fool
cutting
around.
it
Simple elegance
and
artistry,
dismembering
all
it.
under topical.
So here we see the phakic implant coming out gently. And we
Everyone knows
examine
this
it
thing.
completely.
Kindergarten for you guys.
Now I'm proceeding
Capsular
with
excess.
manual
Keep the
capsular
intacts.
access.
Remember, I left the intacts. I didn't remove it because the
Then
cornea is stable
soft
for me.
cataract is
It's a
out,
good
followed
thing.
by irrigation aspiration.
I don't like how the surgeon
I
had done
leave
it, but it's a
behind
good thing.
some
It's stable.
cortex in the
I leave him
subincisional
aphakic and I
area
leave
of the
some
bag to
cortex in
keep
the
it open
subcortical
for
area to leave the
make
bag
it easy
open.
for my next step. At this stage,
And then I put
it is very
Reshore sealant
important
just to
that I
make
have a
sure it
stable
never
anterior
flattens. Remember, you
chamber,
want a stable chamber
and
because I'm going to
this
measure
very
him now.
sure sealant, as you can see
So this is a
here.
very dangerous surgery because it's now on your shoulder.
So my
You're
chamber
carrying
is
this
stable
patient.
now,
Remember,
as well as for the entire
you have to have not only confidence but the patient's trust that he's hanging on to you now. You can't let go. You have to do this perfect because he's waiting for the next step, right? He's constantly checking. He's blind. This is immediate first step.
Morning, Jerry. How are you?
Let's go through this. Here you can see how every patient of mine is so educated, they can actually tell the story. You've seen a lot of this on the social media. And I love to show you all this because the patient has to know what's going on. That's when they become your partners. Look at this. And Dr. Porwal, this is how I explain to them. And they get it. All patients, they understand what you're doing.
A week later,
I go, see the subincisional cortex I just removed? Just flush it out. Now I enter, I've refracted him twice now, day 1 and week 1, which is enough in my experience to get a stable scenario. Going in again,
and I was so confident that I've used a toric lens implant
and high
in this
confidence.
case. And here the lens is seen injected into the
Again,
eye
piece of cake, guys. Can we do this in Rajkot?
capsular bag.
Yes.
Irrigation aspirates to remove any residual viscoelastic and any residual cortex in this high technique, as I've described, for toric lens alignment to be very secure right before.
Let's go a little faster.
Incision 2 and the parasite and reversed him back thematically.
Can I interrupt here, Dr. Gulani?
Go, please.
We've exceeded the time a bit, but still we have extended the session by half an hour. I would want Dr. Ajay Mehta to do his presentation on the Phenocaine Plus for a few minutes, and then you can come back for the closing remarks, Dr. Gulani, if it is okay with you.
Absolutely fine. Absolutely fine. Yes. Go ahead, please.
Dr. Ajay Mehta. Yeah. Your talk on Phenocaine Plus. Try to make it short as much as you can.
I'll stop sharing here.
Excellent cases, unimaginable, Dr. Gulani. We can keep seeing it all night here, but our link is going to work only up to 9 o'clock, I suppose. That's about 20 minutes from now.
Okay, no problem. Should I'm trying to stop share here.
Yeah.
So you can see yourself. There we go. You okay now?
Yeah, great.
Wonderful.
Yeah, Dr. Ajay Mehta will share his screen now. Yeah, it's full screen.
Is it seen?
Yeah, seen and heard. Yes.
Okay. Yes, so good evening, everybody. And it's a real pleasure to hear Dr. Gulani and learn a lot of things here. But there are a few basic requirements for a cataract surgeon, and is an age-old tradition that we dilate our patients' pupils with dilating drops by one of our staff, and we put them once, twice, God knows how many times, and then we put our torches in their eyes, and by the time the patient is inside the room, they are very, very tense. So to replace that practice, we now have this Phenocaine Plus injection available in India. So this injection has a lot of advantages. The biggest is that it is labeled as an intracameral injection, As you all know, we are using a lot of injections which are off-label like Avastin and moxifloxacin. So the advantage here is we don't need any preoperative dilatation. Take the patient inside the OT and inject the solution. It provides rapid mydriasis, gives a pain-free surgery. Not only that, the entire surgery is pain-free. So there is a sustained anesthesia, and this ultimately gives rise to a better surgical outcomes. One thing is it is very helpful in patients who are allergic to phenylephrine eye drops. And the other big advantage is there are no systemic side effects. When you put drops in patients of hypertension and heart diseases, there is always a fear of the hypertension or the blood pressure rising. Now, let me tell you what this contains, the phenocaine injection. Well, there is tropicamide, which is anticholinergic, 0.2 milligram, a very small amount. Phenylephrine of 3.1 milligram, lidocaine 10 milligram, and then we inject a 0.2 ml intracardially. We don't need to inject more because there's no add-on effect, and this can cause endothelial loss. And as I mentioned, it is preservative-free and sterile. So here I just want to highlight some of the articles that I came across in a few of the journals. And the effect on mydriasis, which now is the next question for all the eye surgeons. Once you have achieved mydriasis, how long will it remain? Well, you see here that with the first injection, it is more than 7 millimeter dilatation in 80.8% of patients. It is slightly less than what we achieve with drops. But this effect then lasts throughout the surgery. And if you can see that the drops effect starts wearing off after a while. And by the time we have finished the surgery, the pupil starts constricting when you have dilated with drops. But when you have used phenocaine, this effect still is maintained. I want to mention some other studies where it has been shown that at one with post-operative...
Can you go on to the video, please? We are running a bit short of time. Sorry to interrupt.
That is fine. And one thing I wanted to tell about the endothelium is there is no effect on the endothelium. This is a British Journal article. Okay, so now what I am trying to show here is this patient is without any dilatation and is having a reacting pupil. And now I am injecting phenocaine, and as soon as it touches, the pupil starts reacting and it starts moving the periphery. And then it takes a while, a few seconds, for it to go for the full dilatation. And as you can see, this is maintained till the end.
Does it dilate fully?
Yes. So this is. I'll show you another case. It depends on what was the pupillary dilatation when you actually had seen the patient 2 or 3 days before in your OPD and after putting dilating drops. So if the pupil dilated say 6 millimeters, then you can achieve at least 5.5 millimeter dilatation. So here again I have put the drops and you can see the effect is almost instantaneous, and then you have to wait for at least 20 to 30 seconds for the entire effect to be achieved. Once that is done, you can continue your surgery the way you always do. So here this patient was dilating fully preoperatively. So now I have already put phenocaine and it has started dilating. It dilates and starts rushing towards the full size. Once it achieves some size, you then have to pressurize the chamber with the viscoelastic to achieve full dilatation. And the best part is this is maintained till the end.
Great.
One bad thing that I noticed about these injections is you have to be very gentle while giving it, otherwise the patient will just start closing his eyes because of the sudden pressure. But even a small amount that is injected is enough to start dilating the pupil and achieving the effect. And as I told, the effect keeps on lasting. You pressurize the chamber, and it stays like this throughout the surgery. You can then very easily perform good cataract surgery because these pupils stay dilated, they stay fixed, and there is no need to worry about any intraocular changes occurring during a surgery. That is how it goes on.
Great.
This is a mature cataract, if you want to see.
Yeah, quickly.
Yes.
So,
again,
Ajay,
very small pupil. And as I told you before, you have to be fast in removing the cannula, otherwise you might touch the dilating pupil.
Oh, okay.
Yeah. It reminds me of sugarcane, adrenaline, atropine, and lidocaine.
Yes, sugarcane does not produce such a good sustained reaction. And through dilatation also.
Yeah, Dr. Tejas had a question, had a comment. Yes, please go ahead.
So, Ajay, does it dilate pupils which have been refractory to dilatation?
No,
that it does not do. But see, this patient was already had a drop put once. So now I want to have full dilatation because I knew that he used to dilate full. Now I injected phenocaine, and you can see the pupil still dilating more and more. You can see that? Red glow is also improving.
I believe it is very important that you assess the pupillary dilatation pre-operatively. If the pupil is resistant to a dilatation, I'm not sure whether phenocaine will
then it will not work.
It won't work. This is only a substitute for the dilating drops.
Yeah,
that's all.
Exactly.
I just wanted people to take home the message.
Yeah, thank you, Dr. Ajay Mehta, for that nice video. Now, can we have Dr. Gulani back for his closing remarks as well as comment on this video, if any?
I'm back. Yes, video is excellent. I think all these technologies are very important at different levels. And
yes, sir.
Absolutely fine. Yes. I still feel every cataract surgeon, I will not let them touch a patient if they can't do cataract beyond 3 millimeters. Very important. There are paradigms I set for my fellow. If beyond 3 millimeters or less than 3 millimeters is an issue, I understand, but beyond 3, they should be easy. How a doctor removes the epithelium tells me how good a surgeon they are. So these are important things I talk about. The pterygium, I hope that doctor was here. Pterygium surgery is the highest level of artistry, where immediately post-op there should be no blood. I don't care what technique is used. If they use, conjunctiva or even the skin, I'm okay, as long as the eye looks perfect and no recurrence. So I hope today, my payback from all of you guys is going to be, you're going to do all this stuff. And never again will you say you're a small place or small practice. I'm here for you. And technology, as I always say, master it. Think of it as like a motorbike or Bentley or whatever you sit on. You are the star. That car is looking good because of you. Don't forget that. All these technologies are amazing, but you're the master. And that's where also, this whole thing I wanted to talk to you about premium and why so many surgeons are in trouble. Stop selling. Let people buy. Got it? They are coming for you. You keep your integrity, ability, attitude, artistry. The rest will happen, I guarantee it. And cataract surgery is nothing more than a 3-4 minute, max 6 minute surgery that leads every patient to vision. I showed you all these cases. These are every day in my institute. For you, I have let my team post on social media. Can you imagine how dangerous that is, guys? Can any of you have each of your patient on social and not us posting? They are writing. And while you're sleeping, people are writing. So imagine the accountability. But it's just to show you that each and every patient who comes to you, some of you ask me a question, how do you deal with celebrities? I have them all the time. I make my celebrities wait. No patient in my institute waits, not even a minute. That's my scheduling style. But you are the celebrity. How can you forget?
One question.
The only reason you keep that status is because of your integrity. If you advertise, schmooze around, play games, do deals, discount, then it's over. Then you can't practice like this. If you keep that up and perform like this, this was cataract surgery, what I showed you. I don't know what people are showing you, all these scary little things. White cataract is piece of cake, guys. When you enter the OR, don't scare your nurses. Just go, this is piece of cake. Surgery is easy. Let me plan on the vision. So your movements will become artistic. You're using no anesthesia other than drops. Patient should walk out, jump with you. That's my request. And your payback, like I said to me, for all my time I've spent today is, you're going to do this.
We'll definitely try and reach higher and higher. And Dr. Om Patel had a question, I suppose.
Yes, sir. That was the question. How do you get your patients to post on Facebook? And how are they ever willing to be in your touch lifelong and
Om.
Yes.
Dr. Om, how do your kids react to you at dinner? If you're a jerk, they won't sit for dinner with you, right? Life is very simple, guys. I'm now doing inspirational talk. It's like I'm your psychologist here. It's very simple. In life, in life, your friends, your kids, your staff treats you exactly the way you deserve. I don't teach anyone anything. I just be who I am. Patient comes in, and remember, again, I repeat, please, these are the world's most demanding patients. The world's most demanding patients in the world's most litigious country. And I do not advertise at all. I don't know if you saw the Egypt guy who just posted, he filled my room with gifts. But he's had 9 failed surgeries. So the point is, I'm trying to answer your question, Om. You and your staff and your kids are always watching you, remember. You can sit down every night and read them the rules of life. They don't care, they're watching. If you cheat, you lie, they will follow you. So the staff, everybody knows I don't shake. I'm always helping my colleagues. But it's a fear factor for them because all the complications of every eye surgeon flies to me. So it's a respectful situation that you got to get to. So you, even if you have just one patient home, don't get scared. Don't worry about money, it'll come. For that one patient, spend your full day. Sit down and chat with them, explain, refract them, do your surgery, mind-blowing. That patient will forever fly their families to you.
That's another issue. How do you manage the time? Because it's not always easy to have unending time for patients, right?
So again, Dr. Mukesh, my style is very simple, like I said. How did I make the time for you today? And how come I crossed 2 hours sitting here on a Saturday when I have so many things to do? Because you care. Very simple. I am the boss of my institute, so are you, correct? You're the boss in your place, right? So who the hell makes your schedule? I decide. Today the Egypt guy is leaving to go back to his country. I'm not going to do anything after 2 o'clock till 3 o'clock. I'm going to have ice cream with him. I just decide. It's simple. I don't want to see 10 patients, more than 10 a day. I've stopped the flights. I stop every day, LA, New York, the surgeons are flying, I stop them. Next 3 days, I'm with my kids. Don't even call me. But every patient has my cell phone. So see, the relation is very unique. They have my cell phone. And I don't have to remember who my 28,000 people are. I just, oh yeah, Kim, how the hell are you? How's Africa? Easy. So what I do is, in my schedule, it's very simple. My biggest thing is, nobody should wait. Because that is an insult to the way I run my practice. So I don't have a waiting room, it's a lobby. It's gorgeous. So the way I schedule is, depending, patients coming from, let's say, New York this Monday, right? She's had 6 RK surgeries and our LASIKs and PTKs and now has cataract. Very nice surgeon, excellent surgeon who's referred her over. I want to have my 1.5 hour because I know what I want, testings. I want to sit down and explain. Nobody for 1.5 hours. I have 3 follow-ups who are coming. One's from, I just saw the schedule while we were talking, Switzerland. One is the local, Jacksonville. One is Tampa, West Coast. Simple. I need 6 minutes with them. The one of the 3 patients wants her daughter to meet me because she wants to be inspired to be a doctor. 15 minutes. No one can disturb me. I'll be talking to her, showing her how doctor is so amazing. So the answer for you, Dr. Om and Dr. Purwal, is I believe just be simple. And do not schmooze with people, otherwise you'll have to do it all your life. Do not do deals, otherwise you'll have to do it all your life. Do not decrease your price, otherwise you'll have to do it all your life. In this town where I practice, I don't even know who practices around here. I have no idea. My price, I keep at the highest. Actually, it's a boon for everybody. Dr. Tejas, you're a wonderful businessman. It's a boon for everybody, right? Because you are keeping your price so high, everybody can charge. Are you with me? Now what happens if you drop?
Very true.
Everybody fails.
We are facing this issue here.
Yes, doctor. I will not forget your text to me, Dr. Om. I haven't forgotten that you said, how do I start my practice? We are facing resistance. I'll tell you this and the way I started my practice. Again, I'm getting late. How I started my practice. I never worry about time and money. My entire focus is patient. And I really love them. And remember again, this is the world's most litigious country, guys. Right? So all I'm saying is, business aspects that I love for you to learn, Dr. Om, not learn, you guys are pretty good, but just don't worry about who's practicing where, but help everybody. That help will come back to you. Help everybody. You see a complication, fix it. That patient will love you, and the doctor, every night he sleeps, will go, oh, wow, I owe that guy, even though he may not say it. So you build your reputation, and one patient at a time. I call my patients tornadoes. You know, they go on Facebook. Do you know they write not 1 line, but 3 paragraphs? And now imagine these are all very, very intelligent, very highly educated, very time-sensitive people. Why are they spending so much time after paying for their surgery? Because when you do the right thing, people get attracted to you. You see all these people, you know, the reason I said yes to you guys, like I said, I didn't want to do any more webinars. I never sit in any auditorium, in any meeting worldwide. I do my talk, I leave. Because I can't listen to fabricated nonsense. It's a waste of my time. People still worried about white cataracts and how do you correct astigmatism, topo-guided nonsense. I'm like, that doesn't exist. So in these webinars, I've learned there's so much problems of ignorance because the guys who are teaching are confused. They're constantly showing posterior capsular X's, how they tear it. Why do you tear it? So if you stick to your ground, even the industry will come around you. Don't bend to anybody. Many doctors who do this for the industry, you know, they lie around because they get a free dinner. The industry knows them now. They know this guy we can always get. We will always aspire for the guy who doesn't come to them.
Yeah, excellent inputs. And I think we have far exceeded the time. And thank you, Dr. Gulani, for your time and wonderful tips. Before we finish, I would request Dr. Tejas Shah to sum up the meeting in a few lines.
Can I interrupt? There was this case that I wanted to ask.
Yeah, sure.
Can I ask it now?
Yeah, go ahead. Go ahead.
So I am sharing the screen.
Mukesh.
Yeah.
I would also like to have a word.
Yes, sir. After Tejas Bhai, please.
Mukesh, let's Sanjay be safe first. I will do that.
You guys still need me?
Few minutes. It's in response to your talks. Ajay bhai, in your keratoconus case, can we discuss this later because we are 2 hours and anytime the link will go off. Okay. Sorry about that.
That's fine.
Dr. Gadre sir, please.
Dr. Gulani, I hope you are listening.
Yes, I am.
Hello.
Yes, I am.
Dr. Ajay bhai, can you stop sharing?
Get the slides off, please.
Yeah. You're on, sir.
Dr. Gulani, at the outset, let me thank you very much on behalf of Rajkot Ophthalmic Society, though I am not a office boy there anymore, but of the senior most members. It has been an amazing sort of experience. Actually, you deal with such complicated situations. We have never faced it before. So our thinking process is quite traditional and conventional. but you have really opened new sort of vistas and ways of thinking which are amazing actually, and you are really a maverick, and would like to come and see how you work, and I must really thank you for spending so much time with us. Thank you very much. Pages, please, you can go ahead.
Yeah. I'm sure many people would be itching to come to Jacksonville, Dr. Gulani, to see you work.
Very true, and it's a very nice place to be. Hi Arun, good morning.
How are you?
I am fine, thank you. So while I was listening to you, as always, I went to Einstein, because I believe you're Einstein to ophthalmology, and I could read two quotes which I would like to share with all of us right now. One of them is, imagination is more important than knowledge, and that's what you actually nailed into each of our heads. Thank you for that. And the second quote that I would like to quote is, I'm enough of an artist to draw freely upon my imagination. Imagination is more important than knowledge. Knowledge is limited, but imagination encircles the world, just like your patients, right? You have your patients from all across the world, but I'm truly amazed at your imagination. Well, many of us in India, in small places or big places, do definitely think like you, but somehow we cannot practice like what you do. I am so blessed actually. In fact, I missed you at the BOA because it did not happen. You remember us sharing this the stage so many times, but well, it always amazes me about your corneoplastic technique. I always say that cornea is something which you can bruise and bend, right? And you actually make use of that cornea very well. I'm so happy. It's the first surface of the eye which actually bends the rays, and you actually use it to your advantage. Awesome, Arun. And I believe, like I said, I'm going to book about 10 or 12 tickets to Jacksonville. Kudos. Thank you. And have a good Saturday. Thank you.
All the best.
Coming to the very end, I would like my secretary of the Rajkot Ophthalmic Society, Dr. Suketu, to finish it with a short vote of thanks.
First of all, I would like to thank Dr. Gulani and team, Dr. Nikki and Dr. Amanda, for spending so much cases and so much time for us. I would like to thank our panelists, Dr. Sanjay Gadre sir, Dr. Lasan Sapowadia sir, Dr. Tejas Shah sir, Dr. Paras Mehta sir, madam, and Dr. Ajay Mehta sir, for spending their valuable Saturday evening for us and sharing their knowledge. I would like to thank at last Entro team, Mr. Raman Marke, for providing such a wonderful platform and providing the extended time for us. Thank you all. Thanks. Thank you all.
And as a last thing, Dr. Gulani, it would be interesting for you to know that the number of people who joined this meeting on various platforms was not as high as 2,000 as you expected, but somewhere close to it, between 1,500 and 2,000 at various points of time.
More important for me is I want you to do this. You can. Your talent is not in question. You're a surgeon. All of this is possible.
And if I can agree not agree more to you about Arun is, you do not sell lenses or equipments. You have to sell yourself. It's your mind and your technique that you need to sell.
Correct.
Awesome.
Correct. Don't sell anything. Just be you.
Yep.
It's
counsel. One of my slides says it's counsel and not sell yourself. Correct?
Yeah.
And that's what you do. You do very well.
Well, thank you so much.
Thank you very much.
Thank you, sir. It was very wonderful.
Thank you so much.